Welcome. Today's challenge features one of the most difficult next-generation NCLEX case studies you'll encounter: septic shock and multiple organ dysfunction syndrome, MODS. These are fast-moving, high-stakes emergencies where every nursing decision can determine a patient's outcome. You'll work through realistic NGN-style scenarios that test clinical judgment, prioritization, cue recognition, intervention selection, and evaluation of patient responses. Read each case carefully. Think like the NCLEX, and choose the safest nursing action before revealing the answer and rationale. Let's begin and see if you're ready for one of the toughest NCLEX case studies.
Question 1. A 67-year-old male with a history of anterior wall myocardial infarction 2 days ago is admitted to the ICU with worsening dyspnea, hypotension, BP 7850 mmHg, and cool, clammy extremities. He is confused and has decreased urine output, less than 20 milliliters per hour. Pulmonary artery catheter readings reveal cardiac output, pulmonary capillary wedge pressure, PCWP, systemic vascular resistance, SVR. Which type of shock is most consistent with this presentation? A. Hypovolemic shock. B. Cardiogenic shock. C. Distributive shock. D. Obstructive shock. Answer: B. Cardiogenic shock. Cardiogenic shock occurs due to pump failure, often after myocardial infarction. The hallmark findings include decreased cardiac output, increased preload, elevated PCWP, and compensatory vasoconstriction, high SVR. The cold, clammy skin and oliguria confirm poor perfusion. Question 2. A 24-year-old trauma patient arrives after a motor vehicle accident with significant blood loss. Vital signs: BP 8246 mmHg, HR 138 bpm, RR 30 per minute, skin is pale and cool. Hemodynamic profile shows CO, PCWP, SVR. What stage/type of shock is this patient most likely experiencing? A. Neurogenic shock. B. Early septic shock. C. Hypovolemic shock. D. Anaphylactic shock. Answer: C. Hypovolemic shock. Hypovolemic shock results from fluid or blood loss. Both preload, PCWP, and cardiac output decrease, while SVR increases as compensation. Tachycardia and cool skin are classic findings. Question 3. A 35-year-old patient develops sudden hypotension during a blood transfusion. Symptoms include wheezing, urticaria, angioedema, and respiratory distress. BP is 70/40 mmHg, HR 120 bpm. What is the primary underlying mechanism of this shock type? A. Loss of vascular tone due to spinal cord injury. B. Reduced preload from hemorrhage. C. Massive vasodilation due to histamine release. D. Mechanical obstruction to blood flow. Answer: C. Massive vasodilation due to histamine release. Anaphylactic shock is a distributive shock caused by Ig-mediated hypersensitivity leading to histamine release. This results in vasodilation, capillary leakage, and bronchoconstriction. Question 4. A 52-year-old male with sepsis from pneumonia presents with warm flushed skin, bounding pulses, BP 90/50 mmHg, and HR 110 bpm. Lab findings show elevated lactate. Which hemodynamic profile is most consistent with early septic shock? A. CO, SVR. B. CO, SVR. C. CO, SVR. D. CO, SVR. Answer: B. CO, SVR. Early septic shock, warm shock, is characterized by vasodilation, low SVR, and increased cardiac output due to compensatory mechanisms. Warm skin and bounding pulses distinguish it from other shock types. Question 5. A patient with a spinal cord injury at T4 presents with hypotension, BP 80/50 mm of mercury, and bradycardia, HR 48 bpm. Skin is warm and dry. What type of shock is most likely? A. Septic shock. B. Cardiogenic shock. C. Neurogenic shock. D. Hypovolemic shock. Answer: C. Neurogenic shock. Neurogenic shock results from loss of sympathetic tone, leading to vasodilation and bradycardia. Warm skin and absence of compensatory tachycardia are key distinguishing features. Question 6. A patient develops sudden chest pain, dyspnea, and hypotension. Imaging confirms a massive pulmonary embolism. What type of shock is this? A. Cardiogenic shock. B. Obstructive shock. C. Distributive shock. D. Hypovolemic shock. Answer: B. Obstructive shock. Obstructive shock occurs due to physical obstruction to blood flow. In pulmonary embolism, right ventricular outflow is blocked, reducing cardiac output. Question 7. A septic patient initially presents with warm extremities but later develops cold, clammy skin, worsening hypotension, and decreased cardiac output. What phase of septic shock is this? A. Early phase, warm shock. B. Late phase, cold shock. C. Compensated phase. D. Recovery phase. Answer: B. Late phase, cold shock. Late septic shock involves myocardial depression, leading to decreased cardiac output and increased SVR, making it resemble cardiogenic shock. Question 8. A patient with severe pancreatitis develops hypotension and tachycardia. There is significant third spacing of fluids into the abdominal cavity. Which shock type best explains this? A. Hypovolemic shock. B. Cardiogenic shock. C. Neurogenic shock. D. Obstructive shock. Answer: A. Hypovolemic shock. Fluid shifts, third spacing, reduce intravascular volume, causing hypovolemic shock even without external bleeding. Question 9. A patient in the ICU has the following hemodynamic values: CO, PCWP, SVR, jugular venous distension present. Which condition is most likely? A. Cardiac tamponade. B. Hypovolemic shock. C. Anaphylactic shock. D. Early septic shock. Answer: A. Cardiac tamponade. Cardiac tamponade is an obstructive shock. Fluid accumulation compresses the heart, leading to decreased cardiac output and increased filling pressures, high PCWP, JVD. Question 10. A burn patient covering 40% of total body surface area presents with hypotension, tachycardia, and decreased urine output. What is the primary cause of shock in this scenario? A. Loss of myocardial contractility. B. Loss of intravascular fluid due to capillary permeability. C. Vasodilation due to spinal cord injury. D. Mechanical obstruction to blood flow. Answer: B. Loss of intravascular fluid due to capillary permeability. Burn shock is a form of hypovolemic shock caused by massive fluid loss through increased capillary permeability and evaporation. Question 11. A 72-year-old female with a history of chronic heart failure presents with acute worsening dyspnea, crackles in both lung fields, and hypotension, BP 8452 mmHg. She is lethargic and has cool extremities. Hemodynamic monitoring reveals CO, PCWP, SVR. Which intervention is the priority to address the underlying shock? A. Rapid infusion of isotonic fluids. B. Administration of vasodilators only. C. Initiation of inotropic support. D. Immediate diuretic therapy. Answer: C. Initiation of inotropic support. This is cardiogenic shock. The primary issue is poor myocardial contractility. Inotropes, e.g., dobutamine, improve cardiac output. Fluids may worsen pulmonary edema. Question 12. A 28-year-old patient presents with septic shock secondary to a urinary tract infection. Despite fluid resuscitation, the patient remains hypotensive with MAP less than 65 mm of mercury. Which medication is most appropriate next? A. Dopamine. B. Norepinephrine. C. Epinephrine. D. Phenylephrine. Answer: B. Norepinephrine. Norepinephrine is the first-line vasopressor in septic shock due to its strong alpha-adrenergic effects, increasing SVR and improving blood pressure. Question 13. A trauma patient initially compensates for blood loss with tachycardia and normal blood pressure. Later, the patient develops hypotension and altered mental status. What stage of shock is this? A. Compensated shock. B. Progressive shock. C. Refractory shock. D. Recovery phase. Answer: B. Progressive shock. In progressive shock, compensatory mechanisms fail, leading to hypotension, worsening perfusion, and organ dysfunction. Question 14. A patient receiving spinal anesthesia develops sudden hypotension and bradycardia. What is the most likely cause? A. Increased vagal tone with loss of sympathetic tone. B. Massive fluid loss. C. Cardiac pump failure. D. Histamine-mediated vasodilation. Answer: A. Increased vagal tone with loss of sympathetic tone. Spinal anesthesia can block sympathetic outflow, leading to neurogenic shock characterized by hypotension and bradycardia. Question 15. A patient presents with anaphylaxis after a bee sting. Which of the following is the first-line treatment? A. 4 fluids. B. Antihistamines. C. Epinephrine. D. Corticosteroids. Answer: C. Epinephrine. Epinephrine is the first-line treatment as it reverses airway constriction, vasodilation, and hypotension rapidly. Question 16. A patient in septic shock develops worsening lactic acidosis despite aggressive treatment. What does elevated lactate most directly indicate? A. Respiratory alkalosis. B. Adequate tissue perfusion. C. Anaerobic metabolism due to hypoperfusion. D. Kidney failure. Answer: C. Anaerobic metabolism due to hypoperfusion. Elevated lactate is a key marker of tissue hypoxia and anaerobic metabolism, indicating inadequate perfusion. Question 17. A patient with tension pneumothorax presents with severe dyspnea, hypotension, tracheal deviation, and absent breath sounds on one side. What is the priority intervention? A. Chest tube insertion. B. Needle decompression. C. Oxygen therapy only. D. Fluid resuscitation. Answer: B. Needle decompression. Tension pneumothorax is an emergency obstructive shock. Immediate needle decompression relieves pressure before definitive chest tube placement. Question 18. A patient with septic shock is receiving norepinephrine but remains hypotensive. Which medication may be added next? A. Vasopressin. B. Furosemide. C. Nitroglycerin. D. Beta blocker. Answer: Vasopressin. Vasopressin is often added in refractory septic shock to enhance vasoconstriction and improve blood pressure. Question 19. A patient develops shock after severe diarrhea and vomiting for 3 days. Vital signs show hypotension, tachycardia, and dry mucous membranes. Which lab finding is most expected? A. Decreased hematocrit. B. Increased hematocrit. C. Decreased sodium. D. Increased potassium. Answer: B. Increased hematocrit. Fluid loss causes hemoconcentration, leading to increased hematocrit in hypovolemic shock. Question 20. A patient in late-stage shock develops multi-organ failure, including renal and hepatic dysfunction. Blood pressure remains critically low despite maximal therapy. What stage of shock is this? A. Compensated. B. Progressive. C. Refractory. D. Recovery. Answer: C. Refractory. Refractory shock is the final stage where irreversible organ damage occurs and the patient does not respond to treatment. Question 21. A 60-year-old male with a history of liver cirrhosis presents with abdominal distension, hypotension, BP 86/48 mmHg, and tachycardia. He has warm extremities and bounding pulses. Laboratory findings show elevated lactate and signs of infection. Which type of shock is most likely present? A. Hypovolemic shock. B. Cardiogenic shock. C. Distributive, septic, shock. D. Obstructive shock. Answer: C. Distributive, septic, shock. This patient exhibits classic early septic shock features. Vasodilation, warm skin, bounding pulses, hypotension, and infection. Cirrhosis increases susceptibility to infections like spontaneous bacterial peritonitis. Question 22. A patient with acute myocardial infarction suddenly develops hypotension, clear lung sounds, and jugular venous distension. Which complication is most likely causing this shock? A. Left ventricular failure. B. Papillary muscle rupture. C. Right ventricular infarction. D. Ventricular septal rupture. Answer: C. Right ventricular infarction. Right ventricular infarction leads to impaired right-sided filling, causing JVD and hypotension with clear lungs, no pulmonary congestion. Question 23. A patient with severe allergic reaction is treated appropriately but develops persistent hypotension due to capillary leakage. What is the most appropriate fluid therapy? A. Hypotonic solution. B. Colloid solution. C. Isotonic crystalloid solution. D. Hypertonic saline. Answer: C. Isotonic crystalloid solution. In anaphylactic shock, large volumes of isotonic fluids, e.g., normal saline, are required to counteract intravascular fluid loss. Question 24. A patient with septic shock develops decreased cardiac output and increased SVR after initial hyperdynamic phase. What does this indicate? A. Recovery phase. B. Transition to hypovolemic shock. C. Late septic, cold, shock. D. Cardiogenic shock only. Answer: C. Late septic, cold, shock. Late septic shock is marked by myocardial depression, decreased CO, and increased SVR, resembling cardiogenic shock. Question 25. A patient presents with hypotension, tachycardia, muffled heart sounds, and distended neck veins. Which condition is most consistent with this triad? A. Pulmonary embolism. B. Cardiac tamponade. C. Tension pneumothorax. D. Neurogenic shock. Answer: B. Cardiac tamponade. This is Beck's triad: hypotension, JVD, and muffled heart sounds, classic for cardiac tamponade causing obstructive shock. Question 26. A patient in hypovolemic shock receives aggressive fluid resuscitation but develops pulmonary edema. What is the most likely explanation? A. Excessive vasoconstriction. B. Fluid overload exceeding cardiac capacity. C. Increased SVR. D. Decreased preload. Answer: B. Fluid overload exceeding cardiac capacity. Excessive fluids can overwhelm the heart, especially if cardiac function is compromised, leading to pulmonary edema. Question 27. A patient with septic shock has the following ABG, pH 7. 28, PaCO2 30 mm of mercury, HCO3 15 milliequivalent/L. What acid-base imbalance is present? A. Respiratory acidosis. B. Metabolic acidosis with respiratory compensation. C. Metabolic alkalosis. D. Mixed alkalosis. Answer, B. Metabolic acidosis with respiratory compensation. Low pH and low bicarbonate indicate metabolic acidosis, due to lactic acid. Low CO2 shows respiratory compensation. Question 28. A patient with spinal cord injury develops neurogenic shock. Which finding is most specific to this condition compared to other shock types? A. Hypotension. B. Tachycardia. C. Bradycardia. D. Cold extremities. Answer, C. Bradycardia. Neurogenic shock uniquely presents with bradycardia due to loss of sympathetic tone. Question 29. A patient with massive pulmonary embolism is in shock. Which hemodynamic change is most expected? A. Increased left ventricular preload. B. Decreased right ventricular afterload. C. Increased right ventricular afterload. D. Decreased SVR. Answer, C. Increased right ventricular afterload. Pulmonary embolism increases resistance in pulmonary circulation, raising right ventricular afterload and reducing cardiac output. Question 30. A patient in shock shows decreased urine output. What is the primary physiological reason? A. Increased renal perfusion. B. Activation of RAS causing fluid loss. C. Reduced renal blood flow due to hypoperfusion. D. Increased glomerular filtration rate. Answer, C. Reduced renal blood flow due to hypoperfusion. Shock reduces renal perfusion, leading to decreased GFR and oliguria as the body prioritizes vital organs. Question 31. A 66-year-old patient with long-standing hypertension presents with acute chest pain followed by hypotension, BP 82/48 mmHg, pulmonary edema, and confusion. Echocardiography reveals severely reduced left ventricular ejection fraction. Which type of shock is most consistent with this presentation? A. Hypovolemic shock. B. Cardiogenic shock. C. Distributive shock. D. Obstructive shock. Answer, B. Cardiogenic shock. The hallmark of cardiogenic shock is pump failure leading to decreased cardiac output and pulmonary congestion. The reduced ejection fraction and pulmonary edema confirm left ventricular failure. Question 32. A 40-year-old patient presents with septic shock secondary to abdominal infection. Despite adequate fluid resuscitation, the patient develops hypotension and requires vasopressors. Which physiological change best explains the persistent hypotension? A. Increased preload. B. Decreased vascular permeability. C. Profound vasodilation and capillary leak. D. Increased myocardial contractility. Answer, C. Profound vasodilation and capillary leak. Septic shock causes widespread vasodilation and increased capillary permeability, leading to relative hypovolemia and persistent hypotension. Question 33. A trauma patient with internal bleeding initially compensates but later shows signs of organ dysfunction including altered mental status and lactic acidosis. What is the most likely stage of shock? A. Initial stage. B. Compensated stage. C. Progressive stage. D. Refractory stage. Answer, C. Progressive stage. In the progressive stage, compensatory mechanisms fail, leading to tissue hypoxia, lactic acidosis, and organ dysfunction. Question 34. A patient with neurogenic shock is being monitored in the ICU. Which intervention is most appropriate to manage hypotension? A. Large volume fluid restriction. B. Vasopressor therapy. C. Immediate diuretics. D. Beta blocker administration. Answer, B. Vasopressor therapy. Neurogenic shock causes vasodilation due to loss of sympathetic tone. Vasopressors help restore vascular tone and blood pressure. Question 35. A patient presents with anaphylactic shock. Which additional symptom would the nurse expect? A. bradycardia. B. Bronchoconstriction. C. Increased SVR. D. Cold, clammy skin. Answer: B. Bronchoconstriction. Anaphylaxis causes airway constriction, vasodilation, and increased capillary permeability. Bronchoconstriction is a key life-threatening feature. Question 36. A patient with cardiac tamponade develops worsening hypotension and decreased cardiac output. What is the definitive treatment? A. Diuretics. B. Pericardiocentesis. C. Vasodilators. D. Fluid restriction. Answer: B. Pericardiocentesis. Cardiac tamponade requires removal of fluid from the pericardial sac to relieve pressure on the heart and restore cardiac output. Question 37. A septic patient's condition worsens with decreasing cardiac output and increasing SVR. Which mechanism is responsible? A. Improved tissue perfusion. B. Myocardial depression. C. Increased oxygen delivery. D. Reduced metabolic demand. Answer: B. Myocardial depression. In late septic shock, inflammatory mediators depress myocardial function, reducing cardiac output. Question 38. A patient with severe burns develops shock within hours of injury. Which mechanism is the primary cause? A. Increased oncotic pressure. B. Massive vasoconstriction. C. Capillary leak leading to fluid loss. D. Increased cardiac output. Answer: C. Capillary leak leading to fluid loss. Burn shock results from increased capillary permeability causing fluid shifts out of the intravascular space. Question 39. A patient in hypovolemic shock shows tachycardia and vasoconstriction. Which hormone is primarily responsible for this compensatory response? A. Insulin. B. Aldosterone. C. Epinephrine. D. Thyroxine. Answer: C. Epinephrine. Epinephrine increases heart rate and vasoconstriction to maintain perfusion during shock. Question 40. A patient with obstructive shock due to pulmonary embolism presents with hypotension and hypoxia. What is the primary goal of treatment? A. Increase blood volume. B. Remove the obstruction. C. Decrease SVR. D. Induce diuresis. Answer: B. Remove the obstruction. Obstructive shock requires relieving the blockage, e.g., thrombolysis for PE, to restore normal blood flow and cardiac output. Question 41. A 70-year-old male with a history of heart failure and chronic kidney disease presents with hypotension, BP 76/42 mm of mercury, confusion, and pulmonary crackles. Urine output is minimal. Hemodynamic monitoring reveals CO, PCWP, SVR. The provider orders 4 fluids. The nurse questions this order. What is the best rationale? A. Fluids will increase SVR excessively. B. Fluids may worsen pulmonary edema. C. Fluids decrease preload. D. Fluids reduce cardiac output. Answer: B. Fluids may worsen pulmonary edema. In cardiogenic shock, the heart cannot pump effectively. Increasing preload with fluids worsens congestion and pulmonary edema, further impairing oxygenation. Question 42. A 29-year-old patient with septic shock suddenly develops mottled skin, decreased cardiac output, and rising lactate despite vasopressors. What is the most likely explanation? A. Transition to compensated shock. B. Onset of neurogenic shock. C. Progression to refractory shock. D. Resolution of infection. Answer: C. Progression to refractory shock. Persistent hypotension and worsening perfusion despite treatment indicate refractory shock, where cellular damage becomes irreversible. Question 43. A patient with tension pneumothorax develops obstructive shock. Which assessment finding is most indicative of worsening condition? A. Improved oxygen saturation. B. Symmetrical chest expansion. C. Tracheal deviation away from affected side. D. Decreased heart rate. Answer, C. Tracheal deviation away from affected side. Tracheal deviation is a late and life-threatening sign of tension pneumothorax due to increasing intrathoracic pressure. Question 44. A patient with severe sepsis is receiving aggressive fluid resuscitation. Which parameter best indicates adequate tissue perfusion? A. Blood pressure. B. Heart rate. C. Urine output. D. Respiratory rate. Answer, C. Urine output. Urine output reflects renal perfusion and is a reliable indicator of adequate systemic perfusion, greater than 0.5 milliliters per kilogram per hour. Question 45. A patient in anaphylactic shock receives epinephrine but continues to have airway compromise. What is the next priority intervention? A. Administer beta blockers. B. Secure the airway, intubation. C. Give diuretics. D. Restrict fluids. Answer, B. Secure the airway, intubation. Airway protection is critical in anaphylaxis due to risk of complete airway obstruction from edema. Question 46. A patient with hypovolemic shock has the following labs: elevated BUN, elevated hematocrit, and increased serum lactate. What does this combination most strongly indicate? A. Fluid overload. B. Adequate perfusion. C. Severe dehydration and hypoperfusion. D. Renal recovery. Answer, C. Severe dehydration and hypoperfusion. Elevated hematocrit indicates hemoconcentration, BUN rises with dehydration, and lactate reflects tissue hypoxia. Question 47. A patient with neurogenic shock is hypotensive and bradycardic. Which medication is most appropriate to treat bradycardia? A. Atropine. B. Dopamine. C. Norepinephrine. D. Vasopressin. Answer, A. Atropine. Atropine increases heart rate by blocking vagal stimulation, addressing the hallmark bradycardia of neurogenic shock. Question 48. A patient in septic shock is found to have decreased responsiveness and worsening metabolic acidosis. What cellular process is primarily responsible? A. Aerobic metabolism. B. Increased ATP production. C. Anaerobic metabolism. D. Decreased glucose utilization. Answer, C. Anaerobic metabolism. Inadequate oxygen delivery forces cells into anaerobic metabolism, producing lactic acid and causing acidosis. Question 49. A patient with obstructive shock due to cardiac tamponade is deteriorating rapidly. Which clinical sign indicates reduced cardiac output? A. Bounding pulses. B. Increased urine output. C. Narrow pulse pressure. D. Warm extremities. Answer, C. Narrow pulse pressure. Reduced stroke volume leads to a narrow pulse pressure, a key sign of decreased cardiac output. Question 50. A critically ill patient progresses through all stages of shock and develops irreversible organ damage despite maximal therapy. Which statement best describes this condition? A. Compensated shock. B. Progressive shock. C. Refractory shock. D. Distributive shock. Answer, C. Refractory shock. Refractory shock represents the terminal stage where perfusion cannot be restored, leading to irreversible organ failure and death.
Congratulations on completing these challenging NGN case studies. Septic shock and MODS demand rapid assessment, early recognition, timely interventions, and continuous reassessment. Exactly the skills the NCLEX is designed to evaluate. If you found some questions difficult, review the rationales, identify why the correct interventions were prioritized, and practice the decision-making process again. Mastering clinical judgment comes through consistent practice with realistic patient scenarios. Thank you for watching, and best wishes as you continue preparing for NCLEX success.